Good afternoon, everyone, and welcome to our webinar on managing common electrolyte disorders, managing dysnatremias, the second installment in our lecture series. So we'll give a few minutes until more attendees join, and we'll proceed. Once again, thank you all for joining us. Yetenaweg is registered in Pennsylvania, USA as a non-profit organization, and it's run entirely by volunteer members. We have more than 70 active volunteer members spanning across 5 different countries and counting more at the moment. As you can see from the right-hand screen, it's an image showcasing our active volunteers. So our engagements can be seen in 4 aspects. The first is through health promotion, which is done via discussion and articles regarding the health of the general public, health policy and its implementation. The second is community engagement, which is done through blood drive, inclusivity trainings, equity projects, and fundraising campaigns. Our third project is through mentorship and skill sharing, which provides direct mentorship, soft skill, career and professional development webinars for healthcare professionals. And our last project is the medical education, which under it has the CME research and quality improvement projects. So Yetenaweg is more than a digital platform. It provides a space where its volunteers can come together and provide to the society in a meaningful manner. This is a slide showcasing our volunteers participating in several activities, including inclusivity trainings, volunteering screenings, and donation campaigns. Our other activities done in collaboration with ROHA and IMSA, which is the article writing competition. So the fourth round of health writing article competition in collaboration with the Ethiopian Medical Student Association and ROHA Medical Campus will be announced shortly. ROHA Medical Campus will award travel grants for 2 health article writing competition winners, whereas Yetenaweg will provide a pulse oximeter for the pulse oximeter and Littmann stethoscope for the top 20 and top 3 winners respectively. And the top 5 winners will also get internship opportunities at ROHA Health and other partner institutions. This is a slide showcasing the winners, the 2021 and the prizes for the 2022 winners. On the left-hand corner, as you can see, is the 2021 winner receiving her prize. And on the right hand, it's a image showcasing the prizes prepared for the 2022 winner. These are the 2023 article writing winners that were provided with the ability to travel abroad. Our other engagement is done with ROHA for the Yetenaweg ROHA Research Fellowship in collaboration with Tukur Ambassa Specialized Hospital and St. Paul Hospital Millennium Medical College. So Yetenaweg ROHA Research Fellowship with Addis Ababa University Medical Faculty. The first round started on March 14th of 2023 with 3 departments, mainly oncology, radiology, and internal medicine. Research grants were awarded for the top 4 winners. The winners have already been announced, and the second round is already well underway. And the other participants were from St. Paul Hospital Millennium Medical College. It was prepared for medical students, mainly interns, and research grant for the top 4 winners were awarded, and the winners have already been announced. As you can see from this slide, these are the winners from Tukur Ambassa Specialized Hospital, 2 residents from internal medicine, another resident from oncology, and another from radiology. And this is a slide showcasing the winners from St. Paul Hospital Millennium Medical College. Okay, when you come to our CME CMEs are freely accessible. And Yetenaweg partners with the Ethiopian Medical Association, with the Ethiopian Society of Cardiac Professionals, and Ethiopian Society of Internal Medicine to provide continued training for healthcare professionals. We've had 21 CME webinars held so far for the year 2024. This is our 22nd. Our average webinar attendees spans from 150 to 200 healthcare professionals. And for 2024 alone, we've planned to hold more than 30 webinars focusing on emergency, surgical and medical case, ENT, pediatrics, OBGYN, and so forth. So we invite both renowned, both local and international speakers. And you can access our previous CME sessions from our Yetenaweg YouTube channel. And in order to get updates about our upcoming CME sessions, you can join Yetenaweg's Telegram channel for healthcare professionals or follow our social media posts. The respective links will be pasted in the chat box below. So in order to get the best experience in the webinar, don't forget to send your questions to the Q&A or directly to the chat box. And at the end of the webinar, your questions will be addressed by the guest speaker accordingly. And to get CEU certificates, you must be able to fulfill the following set of criteria. The first is attend the whole session virtually, because the minutes attended will be checked by Zoom attendee reports. The second is fill the Google form for personal details and attendance. and the SIR is to get 50% and above on the first webinar quiz. So you'll be able to see your results right away, but the process of issuing certificates will take approximately 2 weeks to be delivered to your email. So in the meantime, we ask that you wait patiently. And as is customary, we have created a dedicated Telegram channel where the quiz link will be posted. So the link will be shared in the chat box below. We urge everyone to join that Telegram group in the meantime. It will be shared on Zoom here directly as well. So having said that, I would like to introduce our guest speaker for today. Our guest speaker, Dr. Hasen Arif, is a clinical associate professor in the Division of Nephrology at Thomas Jefferson University Hospital. He completed his medical education from Dow Medical College in Karachi, Pakistan, and completed his residency and fellowship from Drexel University. He's been in academia for the past 10 years. Okay, so Dr. Hasen Arif, we're glad you could join us. Please proceed, and thank you.
Thank you. I will be sharing my screen. Big thank you to Yetenaweg. All those attendees who are on, please give them a big shout out. These CMEs and arrangements are not very easy to conduct. With that, I'm going to share my screen so we can get started. So today we'll be talking about dysnatremias. The way I usually approach any electrolyte or any nephrological issue is usually through cases. That makes them more enjoyable and more interactive. So the entire presentation is primarily based off of cases that can then be utilized by anybody who's either looking at this later on or during the presentation itself to their advantage in their clinical practice. I have no disclosures at this time. So dysnatremias is basically defined as either too high a salt concentration or too low a salt concentration. Basically, it's a ratio between the amount of salt you have in your body versus the amount of water. Patients, usually if they're on the floors, not much happens. These are mild. However, if they are admitted or develop in the ICU, they are poor predictors of mortality. Sodium disorders, normal sodium stays between 136 and 144 milliequivalents per liter. If you're dropped below 135, that's called hyponatremia, and the morbidity and mortality rate is about 20 to 30%. And these are the adjusted risk ratios for hyponatremia. So if it's mild, it's still a positive correlation. If it's severe, it's still a positive correlation. And the other way, if you're above 145 milliequivalents per liter, the mortality and morbidity is about 10 to 20%. And as you can see, there's still a positive correlation with mild and severe hypernatremia as well. So acute versus chronic hyponatremia, in a hypotonic state, basically excessive water gain, you have cerebral swelling, and that cerebral swelling can lead to increase in the size of the brain because water moves from outside to inside. You have a fixed amount of space in the calvaria, and because of that, there is then herniation, and unfortunately can lead to that. Before this happens, patients usually end up with some form of seizures or neurological sequelae. So hopefully, if it's caught early enough, this does not happen. Again, for any particular person asking, adults are allowed at least 8% swelling in the brain before herniation occurs. After that, it doesn't. Sorry. If it is less than 8%, herniation does not occur. Better way to say it. If it is chronic, adaptation occurs, the compensatory mechanisms begin, and the brain basically moves osmoles out of its tissue so that the swelling doesn't occur. And then brain edema is virtually absent. So based on brain imaging, you can actually ascertain whether this is an acute or a chronic phenomena occurring in the body. This is a bar chart showing the mortality of acute versus chronic versus symptomatic versus chronic asymptomatic hyponatremia. And as you can see, in acute situations, the mortality is exponentially higher than chronic with symptomatic hyponatremia. Then chronic asymptomatic hyponatremia. So when approaching hyponatremia, the first thing is to whether the patient has symptoms or not, period. Based on whether they have symptoms or not, then you can kind of figure out what's the next best step. If they are symptomatic, we jump on the symptoms and forget what the cause of the hyponatremia is. If they are chronic, then we can basically take a step back and figure out how it happened, when it happened, and then try to correct it. So two different arms that we can use to figure out how we approach hyponatremic patients. That was acute. Now in the chronic setting, the brain undergoes adaptation, as I just said, with osmoles moving out. So when the osmoles move out, the osmoles outside the body versus osmoles inside the body balance off, and so no water moves in and out, and then you don't develop swelling. However, since you are moving electrolytes out of the brain, your ability or your patient's ability to be as sharp as they were before is blunted. For example, if somebody is chronically hyponatremic with a sodium of 130, shall we say, their answers will be correct, but the answers will be slow. I.e., you ask them what the day is, and instead of saying, today is Saturday, they'll take their sweet time. It'll take them about 10, 15 seconds, and then they'll be like, Doc, it's Saturday. So the answer will be correct, but the neurological manifestation will be there, and you'll be able to pick it up. On the right side of the screen, you're actually seeing a difference in, or at this is actually a mouse bone. These mice are with normal sodiums. These mice are with hyponatremia. And as you can see, there is a difference, a marked difference in their bone density. This mouse bone as stained shows up over here. This mouse bone shows up over here. And as you can see, over a period of time, the patients that we are taking care of who are chronically hyponatremic will develop low bone density. And the reason is, just like if your patient's calcium is low, calcium is leached out from the bone. Bone is a big reservoir for sodium as well. So if you are chronically hyponatremic, sodium moves out of the bone as well, leaving the bone weak. This is called a tandem test. So if you have a pressure mat on the floor underneath this patient, if they are hyponatremic, their balance will be like this, all over the place. As soon as they're corrected, you can see that their balance improves. Same over here, same over here, same over here. So putting all these three scenarios together, the patient's mental acuity is down. From a chronic standpoint, patient's bone density has been depleted and their balance is off. So now you're looking at the perfect trifecta of a scenario where a patient is more likely to fall and break a bone. So chronic hyponatremia may not be neurologically, shall we say, an emergency, but it does need to be treated because of its effect on the body. Now, in the setting of hyponatremia, just like we said, there is a ratio of about how much salt you have to how much water. And in the body, it's usually the water part that kind of goes up and down, leaving the salt the way it is, leading to issues. Now, if your kidneys are normal, you can maintain this amount of osmolality in the body by removing or holding on to water, depending on what the scenario is. So if you chug down a ton of water in a day, you will make a ton of urine because your body doesn't need it. So you can actually get rid of 20 to 25 liters of urine a day if you're drinking 20 to 25 liters of water and you don't need any of it. Consequently, if you're seriously volume depleted or in a scenario where there is water deprivation and you can't have access to water, you can concentrate to your urine down to about half a liter of urine a day without any damage to your body, your blood pressure, or your osmolality. So, not to bore you guys with definitions, we're going to focus on this value in itself as an evaluation of how much salt to water ratio there is in the body. This is the calculation we normally use. It is available online. It is available in your phones. So I'm not going to bore you to death with how do we calculate it and when do we calculate it. Tonicity is effective osmolality. And rather than just staying on this slide, I'll show you an example. These are two patients. Patient X has a high blood urea nitrogen of 90, sodium of 135, and a glucose of 90. When you calculated their osmolality, it's coming out at 307. The osmolality is high. For patient Y, their sugar is 490, their sodium is 135, and their blood urea nitrogen is 30. Their osmolality based off this formula is coming out to be 307 as well. So osmolality-wise, these two patients are identical. Which one has a higher tonicity? And what we'll try to do is through these examples, we're going to look at how osmolality or tonicity are different as opposed to being same. So here is a diagram. This is patient X. Their sugar is 135, sodium is 135, glucose is 90. And the blood urea nitrogen is 90. Now, because the blood urea nitrogen or BUN or urea is lipid soluble, it's going to be equally distributed in all three compartments as it is seen. And hence, it will nullify each other out and there will be no net movement of water between these three compartments, even though the total osmolality is high. Net movement of water is practically zero because they're all canceling each other out. And hence, the amount of water stays the same in all three compartments. Now, we're going to look at patient Y, which had a high sugar level. Okay. The blood urea nitrogen in all three compartments is 30. And you have your water molecules that are, for now, equally distributed as well. Now, when the patient's sugar shoots up to 490, sugar has not moved into this compartment, has not moved into this compartment for now, which will lead to water being pulled from the other compartments into the blood compartment, leading to an increase in the blood vascularity. Why? Carrying more water. And hence, you can say glucose is not only osmotically active, but tonically active as well. The moment you give this patient insulin, glucose will move intracellularly, the water will follow as well, and glucose will lose its tonicity and will become osmotically active, but tonically inactive. So how does one maintain balance in the body? So there has to be a mechanism that controls salt. There has to be a mechanism that controls water. For the salt, we have our renin-angiotensin-aldosterone system. This is basically a very robust system to basically pull back salt into circulation. And depending on which part of the kidney it's working in, there will be consequent reabsorption of water as well. For the most part, they both go hand in hand, which means the ratio of the salt and the water kind of follow each other together. Sorry. And then you have a subsequent secondary mechanism to control the water as well. And that is dependent on your thirst mechanism, where you will hunt down water, and ADH, which can reclaim water that is already available in the body, but not in the right compartment. Okay. So when our osmolality changes, how do we maintain our sodium? Based on what we consume. So if you consume, or if I consumed 800 milliosmoles of, shall we say, proteins and other items, other food items that basically broke down into these chemicals, and I drank 2 liters of water, I want to maintain my body at about 290, which is normal for me, and my sodium at 140. That makes sense. So what does my kidney do? So what it does is, this is the range of my concentrating ability up to 1300 and my diluting ability. The question becomes is, with me being here, do I need any of this? And the answer at this point is no. So what do? I will adjust my urine osmolality and I will get rid of the 800 milliosmoles and the 2 liters of water by making 400 milliosmolar per liter of urine with a total of 2 liters. And all these 800 and 2 liter of water, basically, if you multiply 2 by 4, it becomes 8. And so all the 800 milliosmoles in 2 liters of water are basically urinated out, and you don't have to worry about what's being held back and what's being let go. And that's how the kidney works. And this working occurs as a result of the presence or absence of vasopressin or ADH. So you can maximally dilute when you don't need any extra water in your body, or you can actually concentrate all the way to 1200. Beyond this point, you cannot concentrate anymore, so your thirst mechanism kicks in as well, so that you can have free water or extra water that you can pull back, because the body is kind of like, I can't do any more than this. So you're going to need to find external sources of fluid. Now, this is a diagram of how the aquaporin system with ADH works. This is the blood side. This is the urinary side. This is the cell in the collecting duct. These are aquaporins 3 and 4. They're always in the membrane in itself. This is your aquaporin receptor, or the ADH receptor as we call it. It is a V2 receptor. So what happens is the collecting duct is basically primarily not permeable to water at all. If for whatever reason the patient's sodium goes up or their BP drops below a certain level where it cannot be maintained by renin-angiotensin-aldosterone system, your body releases arginine vasopressin, also called ADH. It acts on this V2 receptor, and through this entire cascade of second messenger systems, the second, or aquaporin 2, is basically placed onto the membrane over here between the urinary lumen and the cell itself, allowing water to flow freely through the cell into where it is required, bringing the sodium concentration down and or normalizing the patient's blood pressure. Once that happens, arginine vasopressin goes away. It has a very, very short half-life, which then shuts this entire process down, making the collecting duct impermeable to water again. So this keeps on happening over and over again. We think this is a one-time deal. It's happening once a day. No, it's happening every minute, depending on what your body is going through. Which is why ADH is such a short half-life. If it had a longer half-life, you'd be pulling back water when you don't need it. So it's released when you absolutely need it. And as soon as it's done its job, it's gone. So hyponatremia is basically defined as sodium less than 135 milliequivalent per liter. So relatively low salt to high water ratio. So in order to kind of figure this out, if your patient doesn't have any symptoms, there are multiple algorithms that you can look into online. I like this one. And I use this one because it makes sense to me. Pick one, choose one, follow one. All of you will get to the same answers, no matter where or how you go about it. So first and foremost, we're going to do one example per kind of hyponatremia. Okay, so that we will walk through the entire algorithm in order to figure out what's happening with our patient. So first and foremost, when you have a patient with hyponatremia, the first thing you do is you look for plasma osmolality. The reason for looking for this is you will be able to categorize your patients into one of these 3 categories. And first category that we're going to look at is called the isotonic hyponatremia or the pseudo-hyponatremia. So let's do a case or an example of this particular scenario. A 69-year-old man was admitted to the hospital for pancreatitis. He underwent blood work while in the hospital and was found to have hyponatremia. Their sodium is 119, their total protein is 4.7, it's a little high. Their plasma osmolality is coming out to be 285, and the normal is 280 to 295. The urine osmolality is given over here, and the urine sodium is given over here as well. So based on the fact that their serum osmolality is falling between a normal range, they are called isoosmolar hyponatremics or pseudo-hyponatremics. Now, why is the sodium low? Well, there are certain reasons that can lead to what is called pseudo-hyponatremia. And it is a spuriously low level because the device that is measuring the sodium for you is not calibrated properly, or it is being, let's say, faked or misled into giving you a false value. Hyperlipidemia and hyperproteinemia are 2 big reasons for why this can occur. And you can confirm that by using a sodium level in the arterial blood gas. Most labs right now are using iron-specific electrodes instead of the flame photocytometry, where this issue kind of usually occurs. So this is how it occurs. This is normally the amount of blood that one would collect. It is spun, and during that spinning, the cell kind of settle down here, and then there's a column of proteins and then a column of water. So what happens is in the flame photocytometry, they're looking at the column of water. So if the column of water is small because there's more proteins or lipids, it's going to give you a falsely low value. So all you have to do is basically ask for the iron selective version, or you can say, please just give me the serum sodium after you've centrifuged it. And this way you'll be able to get an absolute value, or if you're still running into trouble, you can ask for an sodium off of an ABG. This kind of hyponatremia does not need to be treated at all. Once their lipid or their protein values are corrected or treated, the underlying cause, their sodium becomes normal as well. So this particular patient, actually, we will check a serum protein electrophoresis looking for any kind of protein dyscrasia in the form of multiple myeloma, IgM, or Waldenstrom's microglobulinemia, or any other protein dyscrasia that you can think of. We will also check a lipid panel and a CBC just to see if they're sitting on any kind of hypertriglyceridemia, like a familial hypertriglyceridemia. And to check CBC, why? Because the same way you can have this column grow, you can also have this column that can grow, right? So if you have a lymphoma or a leukemia, this column will be higher and it will shrink this column in itself. So through that, we can get to that answer. Now, second kind of category would be this kind of hyponatremia. It is called hypertonic hyponatremia because you got your patient's osmolality and came back at 295 or higher. Okay. So this is called hypertonic hyponatremia. We're going to do a case of this. So hypertonic hyponatremia is measured. So basically what you do is you send your patient serum osmolality and comes back at 290 or above. The diagnosis usually are hyperglycemia, mannitol, glycine, contrast. You can even correct it if you have these calculators for the sodium, for the rise of sugar. So a 20-year-old patient who has been complaining of polyuria, polydipsia, polyphagia for the past week, complains of fatigue, and due to lack of energy, decides to seek medical care. They don't know of any medical condition that they have. Their blood work is shown on the right-hand side. And this is basically our patient Y that you saw earlier. Blood sugars are 490, sodium is 135, BUN is 30, sodium is, and then you do your osmolality, it's coming out at 307, absolutely higher than 295. And again, sugar being tonically active, it will pull water towards itself. So this is an example of hyperosmolar hyponatremia or hypertonic hyponatremia. So again, the same example, and water is basically moving into this compartment, causing actual water to be there. Hence, this is not called pseudo hyponatremia. There's nothing pseudo about it. There is actually extra water in this compartment. Okay. And that leads to a dilution of the sodium. So how do you treat these situations? You will basically treat the underlying cause. And in this situation, it is hyperglycemia. So you will give your patient insulin. They're a type 1 diabetic being diagnosed for the first time. As the glucose dissipates, the water will redistribute and their sodium will become normal. All other causes that can cause this kind of a hypernatremia, but this is not an exclusive list. So please look it up, but these are the more common ones. It could be secondary to mannitol administration. It is seen more commonly in the setting of neurosurgical patients where they've had a brain bleed, and mannitol can be used to reduce the edema in the brain. It can be secondary to high doses of iodated contrast that also have osmotically active properties. My apologies. And can pull water. So until the kidney actually deals with these two, it's going to stick around. Glycerol, it's an old school management of post transurethral prostatectomy. Not practiced very commonly, but it can be used still. And obviously it's glycerol, so it's an alcohol or behaves like a lipophilic substance. So it basically moves from the bladder out into the circulation, and once it gets into the circulation, until it's dealt with again by the kidney, it's going to continue to hold water towards itself. So again, in these three scenarios, treatment of hyponatremia will be let the body deal with this. Once these chemicals are out of the body, the sodium corrects itself. In this particular scenario, you're going to have to treat the underlying cause, which would be the patient's type 1 diabetes, and their sodium will correct itself. Okay. So now we're going to get to the crux of the matter, and this is where all the game begins. So we're going to talk about hypotonic hyponatremia, which is actual reduction of the amount of osmolality. So this is called hypotonic hyponatremia or hypoosmolar hyponatremia. So basically, the body has more water than salt. So if you have more water than salt, what should the kidney do? Should it hold on to water or should it get rid of it? So in a healthy scenario, the kidney will try to get rid of it. And that's how we basically figure out whether there is ADH in the body or not. So if you look at this diagram again, the two arms that we have is either a urine osmolality less than 100 or a greater than 100. So if you or your patient is in this category, automatically, if everything is healthy, the body will move towards this side, which is we want to get rid of the extra water. Hence, the body is making a dilute urine. So your psychogenic polydipsia patients where they're on antipsychotics and the mouth becomes really dry and they take ton of water, acute water intoxication. Somebody told somebody, hey, I'm going to challenge you to drink a gallon over the next 30 minutes. And they were dumb enough to actually accept the challenge and they drank the gallon, and it can actually occur. Also, beer potomania and Tito's, they don't have enough osmoles, so their osmolalities in the urine are already low. So let's talk about a case along these lines if we have one. So hypotonic hyponatremia is a urine with less than 100 osmolality, which means ADH is not present, and these are our documented or differentials that we have. And the history will be telling to you as to what is happening or how it has occurred. So all we have to do is basically free water restrict. If they don't have access to water, they're not going to drink. If they're not going to drink, their sodiums are going to come back up. So you basically don't have to do much in this management anyway. Now, the other side of the column is more important. This is where, for whatever reason, the kidney that should be getting rid of the extra water is not getting rid of the extra water. Okay? And now, first and foremost, we're going to talk about a scenario which is hypovolemic hyponatremia. So as you can see, we went from plasma osmolality, urine osmolality, and then you've basically gotten to a point where you're going to do your physical evaluation of your patient, where their physical exam, their JVD, their crackles, their edema, their orthostatic hypotension, all that is going to come together to give you the absolute correct answer. So right now we're going to be dealing with these three entities: hypovolemia, hypervolemia, or euvolemic hyponatremia, because again, the ADH was greater than 100. So first we'll deal with hypovolemic hyponatremia. So this is an example of, let's just say, hypothetically, this is your blood compartment, and this is basically breaking the body or the blood compartment down into different percentiles of how much you have. So as a scenario, unfortunately, I am in Philadelphia. The chances of this happening are real, but hopefully it'll never happen. We'll see. So if I got shot and I lost at least less than 10% of my circulatory volume, in order to fill my body, if I'm not able to get to a hospital, my body will basically kick in order to help me survive. And in order to help me survive, it's going to do and release all the pressures that I have in my adrenal glands, which will cause vasoconstriction to bring my blood pressure up. And it's going to activate the renin-angiotensin-aldosterone system to hold back salt and water and bring my volume back up without any drop in my sodium. Now, God forbid, if I lost more than 10% of my volume, these two mechanisms are not going to be enough to keep me or to help me survive. So at that point, a third mechanism kicks in, which is the release of ADH. So ADH has two releases, a fine-tuned release, which is maintaining osmolality, and a number two release, which is life-saving release, primarily when we lose more than 10% of your circulatory volume. So hypovolemic hyponatremia can occur due to a number of reasons. It could be because of diuretics. It could be because of dehydration, diarrhea, nausea, vomiting, blood loss. All that stuff can occur. Treatment is basically volume resuscitation. And once you get the circulatory volume corrected, you don't need ADH anymore. ADH shuts down and your sodium starts correcting on its own without you having to do anything. Actively, we didn't give the patient anything to treat their sodium. We basically gave them what they needed, which is volume. And the best way to replete somebody's volume is either give them what they lost, which is blood, in case of the case that we did, or give them fluids if they're losing fluids, for example, in the case of nausea, vomiting, diarrhea. So either or, you basically decide what you might want to choose in order to treat your patients. Okay, so again, looking at the urine osmolality, we went over here now because it's still high. This is where your physical exam comes into play. You're going to look for all the signs of volume overload in your patient. So a 40-year-old patient with ischemic cardiomyopathy ran out of her diuretics for 4 days. Patient's estimated dry weight is 70 kilos. Admission weight is 80 kilos. So this is not muscle. Over this time, the patient unfortunately has gathered or gained what is called fluid. The exam, they are vitally stable. There's positive JVD, crackles at the base, bilateral lower extremity edema, and the sodium levels are low. Excuse me. So, hypervolemic hyponatremia would be your clinical differential. Differentials are either congestive heart failure, cirrhosis, or nephrotic syndrome. And typically, urinary sodium is less than 20 unless they were on diuretics. Why? Because diuretics will spuriously make this number go up. How will you treat these patients? The problem is extra water as a result of the body being faked into thinking that their circulatory volume has dropped more than 10%, just like the gunshot patient, right? So the body is being faked into thinking, dude, something's wrong. So the fluid and the volume is there, it's just in the wrong compartment. The kidney is being faked into thinking, hey, we still don't have enough to circulate. And the kidney keeps on holding on to salt and water, and the heart keeps on having to deal with the extra volume, and it keeps on tiring out, and you get into this vicious cycle, and that's how you get into decompensated congestive cardiac failure. So these patients are, and this is going to be for your knowledge, they're going to be salt and water up. The only difference is that their water content is higher than their salt content. So how do we prove that? So let's look at this patient when they were at their dry weight, which is 70 kilos. For a 70 kilo patient, the sodium being at 140, 70 times 60% is 42 liters, which is the total body water. If you multiply 42 with 140, you get about 5880. This is completely theoretical. You don't have to do it, but this is a concept that will help you later on in life. Now, versus this particular scenario that we're doing, the patient normally was at 70 kilos. They put an R up to 80 kilos. 70 times 60% is 42. So we're still taking that 42. And this extra 10 kilos is what? 10 liters of water. So 42 plus 10 is 52. And 52 times 135, which was the sodium of our patient, you can see they are sitting at 7020 milliequivalents of total salt. Definitely higher than this, even though It may look like 140 is higher than 135, but overall, conceptually and mathematically speaking, these patients, these heart failure patients are definitely higher than on their salt content than their water content. And that is why you can treat them with diuretics. You can actually hit them with a ton of diuretics, whether they're thiazides, loops, combinations, and you will be able to get rid of the salt and the water, and the circulation gets better and life becomes good. Consequently, if you're having difficulty with diuresis, you can use what is called Vaptans, and they will basically block the aquaporin portion. The patient will lose the extra water, which is the 10 liters that you see over here, and life will become normal again. Now, the last and the final portion of this entire thing, which was the urine osmolality, we looked at all these three, and now we're sitting right in the middle over here. So now you have a patient who is low on their salt, their plasma osmolality is low, their urine osmolality is high. Sorry. But now you come to the bedside and you're looking at them. You set them up. They did not tilt. They are not orthostatic. They looked for a JVD. There's no JVD. You heard or looked for crackles. There's no crackles. They don't have a hepatojugular reflex. There's no ascites. There's no lower extremity edema. Their blood pressures are beautiful. They don't have an extra ounce of edema in their legs. So you would define them as euvolemic based on your physical exam. These are patients that are called euvolemic hyponatremics. So let's do an example. An 88-year-old patient is admitted with abnormal labs. They take omeprazole, which is a proton pump inhibitor, metoprolol, which is a beta blocker, aripiprazole, which is an antidepressant, aspirin, and simvastatin, which is a cholesterol medication. Serum sodium 120, potassium 2.5, chloride 90, creatinine 0.5, BUN 20, glucose 100, uric acid is less than 2, measured osmolality is 250. So looking at that same algorithm, sorry, you're seeing a patient that has hypoosmolar hyponatremia. And these are the urine tests. Okay. Orthostatics, blood pressures are beautiful, no orthostatics, heart rate is good, respiratory rate, moist mucous membranes, no JVD, rhythm is regular, S1, S2, chest is clear bilaterally, abdomen soft, non-tender, no edema noted. So I'm going to put this every time we're going to do a question so that we can walk our way through it. So plasma osmolality, here it is, measured is 230. So based on that, they're either falling here, in the middle, or over here. So again, look at your, in your mind, just decide, do you think they fall over here, or over here? And the answer is they fall in this category. There's no tricks about it. This is just the schema that we're going to follow. So since we're in this category, we kind of have to look at the urine osmolality, and the urine osmolality could either be less than 100 or greater than 100. So based off of that, the urine osmolality that you measured came out at 500. So where do you think the patient falls, over here or over here? Again, no tricks. There's nothing to trick you guys with. The urine osmolality is 500. So the patient falls over here, and based on their physical exam that you did, they're falling where? Over here, or in the middle? And the answer is they're falling in the middle. Why? Because they did not have either any signs of low volume or low circulatory volume or high circulatory volume. So you're kind of left right in the middle, which is called euvolemic hypoosmolar hyponatremia. So working through this question, do you think they have Beer-Portomenia-Tito syndrome? If you looked at the urine osmolality, it should be less than 100. In this patient, the urine osmolality was like 500. So Beer-Portomenia is out. Do you think they're dehydrated? Well, your physical exam is saying otherwise, so they're not dehydrated. Do you think they were drinking too much water? Can't be the case. The urine osmolality is greater than 100. So primary polydipsia is out as well. And again, your physical exam was negative for any volume overload. So they can't be congestive heart failure either. So the only option left is SIAD. My apologies. SIADH. So now that you've come to the diagnosis, patient right now has no neurological sequelae. So what do? You basically DC the offending agent. And again, there's a laundry list of medications that can cause SIADH and SSRIs or serotonin inhibitor uptake. Sorry, serotonin selective serotonin receptor inhibitors are notoriously known to cause this. So DC the antidepressant. My apologies. And if your patient does not have any symptoms, you don't have to really do anything. Let their sodium come up as the medication washes out of their circulation. In order to be safe, monitor their circulatory sodium and try to make sure that they don't correct for more than 8 milliequivalents in 24 hours. So the reason why it's called syndrome of inappropriate ADH is because the two triggers for ADH release are what? High osmolality in the blood and volume or circulatory volume issues. The patient is not fitting either one of these criteria, right? From an osmolality standpoint, their osmolality is low. So why should ADH be there to begin with? And number two, their circulatory volume is perfect. They're not volume underloaded or overloaded. So why should ADH be there? So barring these two causes for release of ADH, for whatever reason, ADH is still there. And that is why it's called syndrome of inappropriate ADH. In order to diagnose this, you have to make sure your patient's thyroid function is normal. They're not adrenally insufficient, so check a cortisol. And they haven't drank ton and ton of water. So these are the diagnostic criteria. Serum osmolality less than 270, urine osmolality greater than 100. They have to be clinically euvolemic, which means that you have to go see the patient. The urine sodium concentration can be elevated. And in the absence of adrenal, thyroid, and pituitary disorders. Okay. So if your patient has had pituitary surgery or they're adrenally insufficient, you cannot label them as SIADH. All these drugs can cause SIADH. All these malignant conditions, sorry, not malignant, but medical conditions can cause SIADH as well. Ecstasy, a particular recreational drug, it basically behaves like ADH in itself. It goes and sits on the receptor of the V2 receptor that we showed earlier and basically activates it and allows you to hold on to water when you basically don't need it. So if the medication washes out, sodium gets better. So this is just a side note for you guys. So what happens when in SIADH, you can use Vaptans. So again, the water portion is impermeable as far as the collecting tubule is concerned. Arginine vasopressin is released in the setting of SIADH without any triggers. It activates all of this and allows water to come through. Vaptans basically stop this, stop the aquaporin from being embedded in that area, making you pee out the extra water. Now, when we're treating SIADH, the rationale of why we need to fluid restrict. So I will talk to you about a concept that we have, and that concept is called the concept of obligate water versus free water. So in this particular area, you'll have your osmoles, which will be surrounded by water, and that's how you basically dissolve them. And you will have extra water that you can actually use to get rid of it. So this is obligated to leave with the sodium. we don't pee out crystals of salt, right? So this is dissolved, and that's why we have an obligate and a free circulation. And so over time, if we cut down the amount of free water that the patient is drinking in, we will cut down the amount of free water that can come in through these aquaporin channels that unfortunately in this scenario are open. The second is we can use salt tablets or any other osmol. So if you add more salt to the patient's diet, their blood pressures are good. Do you think they need the salt? And the answer is no. Why? Because you only need salt when you need blood pressure. If your blood pressure is good, you'll pee out the extra salt. So in order for them to pee out the extra salt molecules, they will link up with the extra free water and making that free water an obligated water to leave with the salt. So you've already cut down on the free water. You're making more of the water to be obligated to leave with these, leaving very little free water to kind of sneak back in. So that's number two. That's the second trick that we try on SIADH patients. The third trick is, now that you've done all of this, which is free water restriction, you're adding salt to the patient's diet. Now, water will flow. Why? Because you have a concentration gradient that has developed over here as a result of the loop of Henle, right? And because of this particular loop of Henle, actually this side, not this side, they've labeled it incorrectly. But what you will try to do is you will give the patient diuretics. That diuretic will stop the sodium potassium 2 chloride transporter. This concentration gradient goes away. Concentration gradient goes away. Water can't move from its higher concentration to its lower concentration. And we basically pee out the extra water. And if all else fails, in the end, all you have to do is give them Vaptans, which will basically stop the aquaporin. So it doesn't matter how much salt you have, how much free water you have, what kind of concentration gradient. You've closed the gates down here. Everything shuts down. The patient starts peeing out 10 tons and tons of water. Okay, now give me 1 second. I'm just going to quickly look at the questions. Oh, okay. So why SIADH doesn't develop edema and hypertension? So the reason for SIADH not developing edema is edema occurs as a result of retention of salt. SIADH patients don't hold on to salt. They don't need the salt. They don't have any reason to hold on to the salt because their blood pressures are good. So they pee out the extra salt. The water that is being retained will equally distribute in all tissues and in the circulation as well. Okay, so it doesn't create a discrepancy between the interstitial space and the vascular space. And because there's no quote-unquote osmol that is showing a discrepancy, like we discussed the case of patient X and patient Y right in the beginning, everything is kind of balanced off. So because everything is balanced off, water is not being trapped in other compartments. And because it's not being trapped in other compartments, including the interstitial place, you do not see any edema in SIADH. It usually stays in the circulation. The fluid will stay in the circulation. Okay. Now, if you have a patient who's symptomatic, the algorithm that I showed you does not, or you cannot follow because your patient is now symptomatic with hyponatremia, right? You kind of have to deal with the symptoms. So we will shift gears. You will want to get back to why the patient developed what they developed. But right now, the premise is to take care of the symptoms first. So God forbid, if you saw a patient and they're having an active seizure, you will want to jump and treat the seizure, which is likely from the hyponatremia, as opposed to leaving or, okay, we'll check the labs and we're waiting for the urine osmolality. No, we have to kind of treat the patient first. So with this, let's do a case. So 54-year-old patient with small cell lung cancer is admitted with a seizure. Patient serum sodium is 112. What would be the most appropriate therapy? Fluid restriction to less than 1 liter a day, sodium chloride tablets, 3% saline infusion, demiclocycline, and conivaptan or tolvaptan. Both are Vaptans. So let's work through this question. The sodium will get better if you fluid restrict the patient. However, it will take a couple of days before that happens. So the poor guy is going to continue to seize, which would not be very healthy for the patient, unfortunately. Sodium chloride tablets can help, just like we discussed in SIADH, they can definitely help with getting rid of the fluid or the extra water from the body. The problem is it's going to be difficult for a patient who is actively seizing to swallow any oral tablet as well. Demiclocycline can actually worsen hyponatremia because it's actually a V2 receptor agonist. So the last thing you want to do is give them a V2 receptor agonist instead of an antagonist. And conivaptan and tolvaptan, again, will take at least 2 to 4 hours before they kick in. So the ideal scenario would be to use 3% saline. Okay, 3% saline has a serum osmolality of about 1000. It has a sodium content of about 513. So it will basically give a lot of salt over a short period of time, and it will correct the sodium pretty quickly. So again, this is something that we've already seen. I'm not going to bore you guys with this. But the thing is, what has happened in the acute situation, the brain hasn't had enough time to kind of move the osmoles out. Osmoles are still here. Your blood count has a low sodium, which means there's enough water there that will move into the brain, and it can cause brain swelling. So it can cause cerebral edema, and that's why patients actively seize. Symptoms usually occur below 125. They could be mild, moderate, and severe. Why wait for a patient to get down all the way here before we do something? So if they're mild, you can kind of get away with working the patient up. And if you can get rid of the offending agents and all that stuff, you can kind of get there. But problems occur kind of over here. So if you're in this particular zone, use what you have at your disposal. Use hypertonic saline. It'll be more effective for your patients. So hyponatremia, obviously fluid restrict, but again, remember, this is dependent on the acuity and the symptoms. So you can fluid restrict these patients. However, it is very less likely to work if your patient's moderate to severe symptoms, and hypertonic saline may be required in that scenario. So this is all the salt supplementation that you have. There's a lot of math. I'm not going to bore you guys. But 1 liter of normal saline basically has 9 grams of salt. 1 liter of hypertonic saline has about 30 grams of salt. So there's a huge amount of salt that can be given through hypertonic saline as opposed to normal saline. Let me go back to the questions. There's another question.
We'll have a separate Q&A session, doctor.
Okay, I'll jump on the questions later on. Sorry, thank you.
Sure.
Okay, so aim for correcting sodium no faster than 8 to 10 milliequivalents in 24 hours or 18 milliequivalents in 48 hours. The reason is, if we correct too quickly, just like water moved into the brain, water can move out as well. And if it moves out, the brain then shrinks. And if it shrinks, it causes damage to not the cells, but it actually causes damage to the fibers that connect the neuronal cell bodies to the conduction pathway. And it can occur in the pons. And that is called what is called the centron-pontine myelinolysis, which is called a Lockton syndrome. So it occurs actually 2 to 5 days after the sodium is corrected. So we can pat ourselves on the back and say, yeah, we corrected the sodium. 5 days to 7 days later, you'll find that the patient cannot move any of their limbs and can only respond by blinking their eyes. That's why it's called Lockton syndrome. And it is something that is unfortunately not reversible. However, what if you caught the patient corrected rapidly, but you caught it? you can actually reduce or actually reverse the damage as well by bringing the patient down to where you wanted them to be. Okay, so it's not like all hope is lost if the patient corrected rapidly. If you catch it as they are correcting rapidly, you can reverse them as well. And you can use D5W, which is basically sugar water, or desmopressin, which was DDAVP, in order to slow the correction of the patient down. And we've done that. We do that all the time as well. Urea can be used just like salt tablets, and obviously Vaptans can be used as well. Starting dose of Vaptans is, the tolvaptan is the only one that's available in the free market. It starts at 7.5. Do not free water restrict these patients. They can have a lot of water loss through the urine, so they can really dehydrate very quickly. There's a very small percentage of liver damage, so avoid using them with anything that has CYP3A inhibitors, such as cimetidine, grapefruit juice, cyclosporin. Avoid using these Vaptans in patients with underlying liver disease. Okay, 73-year-old patient admitted with 5 days history of diarrhea and weakness, takes losartan, hydrochlorothiazide for hypertension. Patient is lethargic. Blood pressure is 120/90, heart rate 100. No edema on physical exam labs. Sodium 110, potassium is 1.7, chloride less than 60, bicarb 37, B1 is 100, creatinine 0.6, urine sodium is 22, urine potassium is 50, urine osmolality is 550. Patient is treated with 2 liters of normal saline and potassium supplementation, and on day 2, they're up to 125. 110, 125. Which of the following best describes the treatment? Potassium chloride to increase serum potassium to above 4 millimoles per liter. 3% saline to increase the sodium to 128 now. Potassium chloride to increase the sodium to greater than 4, and 3% saline to increase the sodium to 128. 1 gram of solumedrol and 3% saline to increase serum sodium to 128. Desmopressin and D5 in water to lower the serum sodium back to 118. So what has happened to the patient? Over here, the patient has come in, they were on a diuretic, their potassium is low, their sodium is low, their chloride is low, their bicarb is high, their urine is concentrated, and their urine sodium is high, likely because of the fact that they're on the thiazide. This is a scenario which we normally see multiple times in our hospital, where the elderly unfortunately keep on taking their diuretics and end up in worse situations than they should. But we know how to correct it, so we took this away. We gave them tons of salt, we gave them potassium, and the next day they went from 110 to 125, which shows you that they corrected over 15 milliequivalents in 24 hours, which means they're at high risk of central pontine myelinolysis. So of these 4 options, do you want to continue to correct them, or do you want to bring them back down to a reasonable value, which will help keep them where they are? And for those of you who've chosen statement E, this statement E is correct, because again, like I said, central pontine myelinolysis will occur 5 days to 7 days from now. You saw they rapidly corrected, you can actually jump and correct them back to where they should be as well. Okay, so answer E is correct. 72-year-old patient with metastatic lung cancer has a sodium of 119, serum uric acid 2.4, and a creatinine of 0.7, euvolemic on exam. Plasma osmolality 248, urine osmolality 664, urine sodium of 100, urine potassium of 66, urine output of 900 ml. What is the diagnosis? Again, we're going to go through this schema in itself. Just walk your way through it. First and foremost, we check the plasma osmolality. The plasma osmolality of this patient is 248, so they fall over here. Okay, they can't be here, they can't be here, because you've measured the plasma osmolality, so they're over here. Based off of that, we look at the urine osmolality, and the urine osmolality in this patient is 664. So they're not over here, which means they're falling over here. My apologies. And based on their physical exam, you can see that they are euvolemic So they're neither here, and they have urinary salt or salt in their urine as well, which means they have SIADH. We're not asking from what, we just need to kind of figure out what it is. So for now, all we'll label this patient is as they have SIADH, okay? So switching gears, we're going to now talk about hypernatremia. Hypernatremia is, again, a relatively high salt to water ratio. It is defined as any serum value greater than 145 milliequivalents per liter. It is again associated with high mortality. Hypernatremia is usually not seen in a lot of scenarios, and the reason why it's not seen is that it is an easier fix by a patient. I.e., when somebody's sodium starts going up, their osmolality goes up, and if their thirst mechanism is intact, what will they do? They will drink extra water, and they will bring themselves back down, okay? Usually, you start seeing hypernatremia in patients who don't have very well or very actively. Okay, let's just put it mildly. They don't have access to water. For example, unfortunately, a patient who's had a really bad stroke and they're now unfortunately bedbound. So until somebody gets to their room and asks them, hey, are you thirsty? Would you like some water? They can't get up on their own to go get some water. So that is the patient that can turn hypernatremic on you. If they also on top of that have CKD, yes, that is possible, right? Because then you lose the ability to concentrate your kidneys to the point where you can still hold on to extra water till somebody shows up and asks you, hey, do you need water? You know? So usually hypernatremia occurs as a result of something else happening to the patient, i.e., they are not able to, or they don't want to, like, for example, elderly patients. We all have elders in our house. You will see that they actively don't go after water. They don't ask for water. The elder they get, the less likely, because they lose their thirst mechanism. Patients who are depressed, patients who have Parkinson's, patients who have dementia, they don't ask for water either. So that can get them into trouble, and you'll see that their sodium over time can keep on climbing over and over, higher than what it's supposed to be. So how do we maintain our sodium? We did this example in the beginning. We adjust our sodium based on how much we consume and what we need. So in this scenario, this individual doesn't need anything coming in, either in the form of salt or water. So they will create a urine osmolality of 400 and basically get rid of all of this, because their osmolality and their serum sodium is exactly where it needs to be. So they don't need the extra water and they don't need the extra osmoles that were consumed. In patients with a functional kidney, regardless of how much you eat or how much you drink, right? If you do not need any of these osmoles, if you do not need any of the extra water, similarly, you will adjust your urine osmolality to what you don't need, and you will get rid of the 720 milliosmoles in 1 liter of urine. The patient will make a urine of 720 milliosmoles, and in 1 liter, they'll get rid of the 720 milliosmoles, and life is good. They don't have to do anything. They don't have to do anything extra. Now, what if they don't have good kidneys, either due to age, kidney injury, chronic kidney disease, any toxins that they've been on, right? They may not be able to get rid of the 720 milliosmoles because the kidney is not able to get to 720. The maximum this kidney can do is 600. So it can do 600 first, but the extra 120 milliosmoles need to be removed as well. So these extra 120 milliosmoles will drag extra 200 ml of water from this patient's body. And over time, 200 ml is a very, very small amount. So one will not see it immediately, but over time, this will continue to happen. This will continue to happen. This will continue to happen. And if they don't drink enough, they will continue to lose. Oh, sorry. and their serum osmolality will start creeping up. Okay. Now, 45-year-old patient with bipolar disorder presents with confusion for 2 days after a gallbladder surgery. Pre-op labs are normal. Patient made NPO past midnight. Post-surgery labs. Sodium is up to 160. Creatinine is normal. Urine volume at 5.5. And urine osmolality is at 100. Okay. It's a scenario that we can normally end up seeing in the hospital. What is the cause of the patient's hypernatremia? Nasogastric tube, osmotic diuresis, diabetes insipidus, and SIADH. So let's have a look. We have some for A, some for D, some for C's. Okay, so let's work through this. SIADH would cause the patient to make a or be hyponatremic, not hyper. Okay, we did hyponatremia and SIADH causes hyponatremia. So D is out. Okay. The patient is making 5 liters of urine. Their sodium has gone up and the urine osmolality is low, meaning with a patient that has extra sodium or high sodium in their blood, they should make a urine that is concentrated. Why? You would want to hold on to the extra water in the urine, right? So the urine osmolality should go up. They should make less urine. Why? Because you're trying to dilute this down. They can't do that. They're not doing that. So something's wrong in the kidney or something's wrong in the body, which means this patient likely has diabetes insipidus. Okay. The definition of diabetes insipidus is polyuria, which is urine greater than 3.5 liters in 24 hours in the setting of hypernatremia and a dilute urine. And this patient is fitting all these 3 criteria. Sodium's up, urine volume is up, urine osmolality is low, meaning it's a dilute urine. Okay. So in the presence of hypernatremia, kidney should maximally concentrate. This patient is not concentrating at all, which leads us to believe this may be some form of diabetes insipidus. The other clue that there is, apologies, is that the patient has bipolar disorder. They may or may not be on lithium. Lithium can cause diabetes insipidus in the kidney. Now, why was the patient normal in the beginning? When they did their pre-op labs, and I'll show you in the question, here we go, pre-op labs were normal. So what was probably happening is that this patient does have diabetes insipidus. As soon as their sodium went up, they would get thirsty, they would reach for the water, they would drink themselves down. They would go to their doctor and say, "Doc, I make a lot of urine." The doctor would ask, "Hey, do you drink a lot of water?" They would say, "Yes." The doctor would say, "Hey, you're drinking a lot of water. That's why you're making a lot of urine." Not putting the relationship that they're making a lot of urine. That's why they're being, or that's why they're drinking a lot of water. Okay. And because they were able to drink themselves back to normal, their labs in the morning or their labs pre-op were normal. Now, what happened is they were made nil per oral post pre-surgery. They went through the surgery. It's about 8 hours since they had anything to eat or drink. They're not allowed to eat or drink post-surgery because obviously they're still NPO passed after surgery. Their access to water was limited, and that's what led to them becoming hypernatremic, and you unmasked a patient with diabetes insipidus. Okay. So this patient actually underwent what is called a water deprivation test. It was done unknowingly because that was not the intention, but it happened nonetheless because the patient was made NPO. Okay. A water deprivation test is one of the ways we kind of decide or differentiate whether the patient has diabetes insipidus. Okay. And the reason for doing this is if you don't allow them to drink, they will continue to pee out extra or all the water that they have in their body because they don't have any ADH or their bodies can't respond to the ADH. So their urine osmolality will never go above 600. Their urine osmols don't change. Their plasma osmolality goes above 300, or they can become hemodynamically unstable. So this is a test where you need to be very carefully present every half an hour to an hour seeing the patient. This is not just a clinical or a lab-based diagnosis. If the patient becomes hemodynamically unstable, you have to break the test right there and then. This is a positive test, okay? That tells you this patient has DI or diabetes insipidus. So if it is central, all you have to do is use desmopressin, which is an ADH analog, or that can then help correct or give the patient the DDAVP they need. Their thirst mechanism is still intact, so they'll drink the water, they'll take the DDAVP, the two will work together, the patient's sodium will come down, and life is good. When it comes to nephrogenic DI, you kind of have to look for reasons why. And in certain cases, it's usually medications that cause nephrogenic DI, and the most common one that we know in the literature is lithium. Lithium doesn't cause it immediately, it causes over time. So your patients will be on lithium for years and years and years for a bipolar disorder, for depression, for something like that. And that's when you'll see it over a period of time. However, it'll only happen when they are NPO, for whatever reason. You will not see it because the patient's thirst mechanism is still intact and they'll keep on drinking water and they'll be fine. Their major complaint to you will be, doc, I make a lot of urine. It's very annoying. And that's you know, something you kind of have to put together to kind of say, hey, something is off. This is kind of like a cheat. What hydrochlorothiazide does is that it actually upregulates aquaporins. And that's how it can help get more fluid into the body. Amiloride basically limits the intake of lithium. So you can actually use this as well. You can use chlorthalidone as well. But again, this is a technical issue that's best left for us. But if you do make the diagnosis, it helps us out as well because we can directly jump onto the treatment for the patient as opposed to having to work them up from scratch. Now, remember, stopping the lithium is not going to make things better. The damage is done. It's chronic. And the patient will fight you tooth and nail. Why? Because lithium, for whatever reason, is one of the best. My apologies. One of the cheapest and the most well tolerated and the best medication for a bipolar patient. It keeps them where they are. It gives them a normal life. They will not come off lithium no matter what you tell them. So don't even try to fight that battle. Okay. So with that, we are actually going to do a few questions.
Excuse me, Dr.
Okay.
Hasan.
Yes.
Apologies for the interruption. So some of the questions for our post-CME quiz are actually taken from this, so we can attempt them after the quiz, if that's all right with you.
Yes, yes, perfect. Would you like me to answer the question and answer session, or should we do that in the end?
No, we'll share our screen. My co-host, Dr. Simon, will read out the questions to you, and we can go back and forth.
Okay, perfect. I'm going to unshare the screen now.
Sure. So thank you very much. That was a very interesting and engaging session. So your expertise and the clear and engaging delivery made the concept accessible. So for that, thank you very much. My co-host, Dr. Simon, has shared the screen and we can go over the questions. In the meantime, to our attendees, please don't forget to join our Telegram channel. Okay, thank you.
Okay, is my screen visible, doctor?
Yes, sir.
Okay, so far we have only collected 2 questions, but we'll keep adding on them if there are more.
Mhm.
So the first question reads, what is the difference between cerebral salt wasting syndrome versus SIADH?
Okay, perfect. So cerebral salt wasting is a phenomena that is poorly understood, but it does exist. It is an existing pathological condition that occurs in patients who have undergone. For the first criteria is they need to have some kind of cerebral surgery. It could be subdural hematoma evacuation. It could be postcraniotomy, VP shunt, something like that that has happened at or around the brain. For whatever reason, the signals that come from the brain all the way to the kidney make the kidney lose salt. Okay. Now, in SIADH, you see salt in the urine as well, right? Both of them are kind of looking the same. However, in cerebral salt wasting, the physical exam of the patient is different. In cerebral salt wasting, the kidney is being made to lose salt, which means the patient's blood pressure goes down. In SIADH, the patient is losing salt, not because they're losing salt, but because of the fact that they don't need the salt. So the difference between the two is in cerebral salt wasting, your patient will have some form of cranial intervention. They will start losing salt, and what will happen to them is that they will become hemodynamically unstable. This is the only scenario where your patient will actually require further, where actually the hyponatremia is because of salt loss, not because of excessive water. Now in SIADH, your patient has urine salt, has salt in the urine because they don't need it. They're not losing it, they just don't need it. So that's the difference between the two.
Okay. Thank you very much for that. The second question we have is there any place to use 3% hypertonic saline?
Yes. So there are two scenarios where you use hypertonic saline. One of them is when your patient is symptomatic. So that is when you use hypertonic saline. Hypertonic saline is usually used in boluses. The best way to use it is in 50 ml aliquots at a time, to be given over 10 to 15 minutes, like a push, like a quick push. If your patient is having seizure from hyponatremia, you give the push, you walk away for about 10 minutes. If the seizure breaks, good, you can do that thrice. And your goal is to basically bring up the sodium from whatever the value is to about 4 to 6 milliequivalents in the next 10 to 15 minutes. The moment you do it, life is good. Okay? So that is where hypertonic saline is used in the hospital setting. There's a second place where you can use hypertonic saline. And if those of you who didn't know it, or those who don't run marathons, you will find out that they will ask you to sign a waiver saying that, do you have any neurological issues, i.e., are you prone to having seizures, or are you on any seizure medication? The reason why they ask is people who run long marathons, they will lose a lot of salt, especially if they have not trained. And if the environment is really hot and humid, they can actually, what's it called? They can actually develop, they will drink regular run-of-the-mill water because they're running and they can only get access to this. So they will dilute themselves down. And in the field, they will use hypertonic saline. So I saw one of the questions saying there's no hypertonic saline available in Ethiopia. Was that one of the questions, or in the question and answer?
Yes, it
No,
was one of the questions, doctor.
Okay, okay. So the one, that's why I said, so normal saline is 9 grams of salt in 1 liter of water. If your pharmacy can add 30 grams of salt to 1 liter of water, you have your 3% saline. Do you have bicarbonate ampules in the medical facilities?
Yes, some of the institutions do.
Okay, so that bicarbonate ampule is your hypertonic saline infusion in itself. Okay. So in certain institutions, you have a hypertonic, you have bicarbonate amps, which is basically 50 milliequivalents of hypernatremia. Sorry, 50 milliequivalents of sodium and 50 milliequivalents of bicarb in 50 mLs of fluid. That is your hypertonic saline one shot. So if your patient is seizing actively in front of you due to hyponatremia, you take that entire amp in a syringe and you can push it into your patient, and their sodium will come up. Okay. So those who have it, good. Those who don't, ask your hospitals if they can stock some, if not a little bit, in case you run into that kind of a situation. Okay. So that's the workaround. If you don't have already hypertonic saline made or available in the hospital. Question number 3 is regarding management of hypernatremia. After calculating the deficit, what should be the ideal fluid for treatment, especially those presenting with sodiums above 180 and below 200? D5, 5% dextrose would be the best solution. You can actually use normal saline as well. Remember, normal saline is about 154 milliequivalents. If your patient is sitting at 180, you will still be able to get them down because the solution that you're giving is still more dilute and has more water than the patient. So you can actually use it to your advantage to prevent rapid correction. You can use Ringer's lactate. You can use osmolyte. All these different solutions, which technically will be lower than the patient themselves, can be used as well. If you're really brave, you can use D5, but you're going to really have to keep an eye on the patient because you're going to have to keep on checking their sodiums frequently to make sure that they're not dropping very quickly. Question number 4 is, how do we treat osmotic demyelination? Yes.
Okay, the first question reads, how do we treat osmotic demyelination syndrome?
Yes. So unfortunately, so there's 2 ways. Remember, once it occurs, there's no treatment. In order to prevent it from occurring, you can slow down the rapid correction of the patient. Which is why, as far as the US is concerned, those patients that do develop osmotic demyelination syndrome, they end up suing the physician as well as the institution because there's no treatment for it. And we have a lot of literature saying that, why did you correct it so quickly? Well, I mean, we all have tons and tons of literature saying that it shouldn't be corrected rapidly. So it falls on us. Yes. And question number 5.
How do you grade the efficacy of hydrochlorothiazide in treating nephrogenic diabetes insipidus in the absence of other medications?
Okay, so hydrochlorothiazide, we start off at 12.5. The way we grade the efficacy, and this would be different for each individual, will be based on the clinical picture of the patient, i.e., how much urine are you making? Has it gotten better? How many bottles of water do you have to drink a day? Has that gotten lower? Why? Because in nephrogenic DI, the patient was making too much urine, which was the dilute urine, and they were drinking because they had to chase it down, right? It wasn't the other way around. It wasn't they were drinking too much water and making the urine. It was the other way around. They're making a lot of urine and they have to drink themselves down. So the patient will tell you, Doc, this dose is working for me. My urine output has gotten better. It's not 3 liters. I make 2 liters now, or I make 1.5 liters now because of the diuretic. And I only have to drink maybe 4 bottles of water instead of the usual 8 or 9 that I was drinking. So it's a clinical answer as opposed to checking the sodium, because for a patient who has nephrogenic DI, they will be normal in the outpatient setting anyway. They drink normal water. Their thirst mechanism is good, so you won't see them at 147, 149, 155, something like that, So next is
Thank
question
you
number
very much.
Yes.
The sixth question is there a cut point of hyponatremia to start management?
So in the beginning, remember we saw that slide pertaining to the acute part. Obviously, you won't wait for a particular value, right? Regardless, I mean, some patients can have low sodium, can have a seizure at 125, some can have a seizure of 130, right? So that is completely separate. You saw those slides pertaining to the chronic patient as well, where they were losing bone density, where their gait was disturbed. So anybody below 135, I would say that they need to be appropriately worked up, and then they need to be treated for it as well. Why? Because in the long run, they're going to lose bone mass, their balance is going to be off, and their reflexes are going to be blunted as well. So now you have a patient who can't balance properly, who can't make a quick decision, and they have bad bones. So you're having a awesome recipe for a disaster, unfortunately, for a patient who can fall and break a hip, unfortunately. So any sodium would be treated. It's just a matter of how aggressive you have to be. So if they're symptomatic, you would be obviously more aggressive. But if they're mild, you still treat them and get them to as high as you can.
Okay, thank you very much. The eighth question reads, can we use 5% dextrose in water for hypernatremia?
Yes, we can.
Okay, thank you. The eighth question reads, we don't usually have access to desmopressin. So for patients who was on therapy for hyponatremia management, and if the sodium dropped rapidly, how much 5% dextrose in water should be used, and at what infusion rate?
Okay, so this would technically require the patient's weight, what they were at, how much fluid was given. For the most part, even though I had mentioned that we can use desmopressin to prevent them from correcting too rapidly, the D5 amount that you're giving them, if they're not responding to it, you double up on it. So if they were not responding to, so for example, patient came in, like the example that we studied earlier, of a patient that came in at 110, corrected to 124 very quickly over 24 hours, right? The amount of D5 that you would have to give would be, shall we say, if it's a 50 kilo patient, their volume of distribution is 25. Can I hijack the screen again, please? I think I have
Sure, you can. You can, doctor.
perfect.
Please proceed.
Okay. So this is the free water calculator that we use for hypernatremia. You can actually use it for hyponatremia as well. Let me show you. Okay. Let's do a quick example. I have a male patient. They're an adult. Their weight in kilograms is 70. Okay. Now, this is a patient that came in with hyponatremia, and we unfortunately rapidly corrected them. Okay. So what if this patient was sitting at 128, okay? And you wanted to get them back down to 120. Here is their free water deficit, about 3 liters, which means 3 liters to be given in 24 hours, which would mean if you need to give 1 liter in a day, it's 40 ml. So your rate of D5 would be 120 ml for a 70 kilo patient. So you can actually cheat your way and use this formula to figure out how much D5 to start the patient on, how much D5 to give the patient to kind of correct them back down as well. Okay. These are all calculators that are available online. Okay. That's why I don't put them in the presentation, because you don't need, your brain power should be interpretation, not to memorize what these formulas do,
Thank you very much, Dr. Hasen. So will you share our screen? Okay, so the next question reads, what is the acceptable serum sodium drop level per 24 hours?
So it's usually 8 milliequivalents in 24 hours.
Okay, thank you.
Same as hyponatremia. Let's just put it that way.
Thank you. The 10th question reads, cirrhosis plus hyponatremia. How do you manage that? And how do cirrhotic patients tolerate significant hyponatremia without developing any symptoms?
This is an excellent question. Hyponatremia in cirrhotics is very difficult to treat. Part and parcel of their hyponatremia is secondary to the fact that they drink themselves down. So free water restriction is a cornerstone. Now, increasing their osmolar load, the problem becomes is they don't tolerate salt very well because it kind of goes straight into their belly, meaning to say it helps out with their, or it causes their ascites to get worse. If you try to give them a high protein diet, it can agitate their hepatic encephalopathy because protein will convert to ammonia. In these patients, sometimes, and again, I know it's a disclaimer on the medication itself, but we do use tolvaptan sometimes. Remember, their liver is already, unfortunately, cirrhotic. There's not much damage that medication can do. In acute symptoms, we do give them hypertonic saline as well. Now, how do cirrhotics patients tolerate significant hyponatremia without symptoms? The truth of the matter is that they do have symptoms. We just don't look for them. If you see the cirrhotic and you guys are probably seeing them because you've asked this question. If you ask them the question, their answering will be slow. It will be correct, but it will be slow. If you ask them to draw a six-sided star, if you ask them to draw a clock face with the hands, the minute hand and the 1 and 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, that will be off as well. If you ask them to walk, you'll see that their gait is unstable. If you do a bone scan on them, their T-scores will be horrible. So the fact that they can tolerate it doesn't mean that they are not out of the woods. It's just that their bodies have adjusted. The body is very forgiving. It can adjust. It's just that it's going to cause more problems for these patients. So yes, they need to be treated. It's a complex format of treating them. We do cheat our way with hypertonic saline. We do cheat our way with tolvaptan. And technically, there's no cirrhotic patient that has no symptoms when they're hyponatremic. They all have symptoms. Any patient below 135 will have symptoms. We just have to look for them.
Thank you very much. The 11th question reads, by how much does hypertonic saline improve the osmolarity?
So that will depend on how big or small your patient is. Remember, the amount of hypertonic saline that you're giving is a fixed amount. It has to distribute in either a really small patient or a really big patient. And based off of that, if your patient is big, you might need to give them more. If you have a small patient, you might have to give them less. So the only way you'll find out is if you give the hypertonic saline and you see the response. And the response is not to wait for the lab to come back, but to see if the seizure breaks. If the seizure breaks with the first dose, you've raised them by 4 to 6 milliequivalents. If the seizure doesn't break, the salt has distributed. Probably it's a bigger patient and you need to give your second dose. If the seizure broke, you've raised them by 4 to 6 milliequivalents per liter. If the seizure hasn't broken, then your third and final dose should go in. And that should break the seizure. So overall, 150 milliequivalents of hypertonic saline can be given. And depending on the size of your patient, the amount can go up by 4 to 6 milliequivalents.
Okay, thank you very much. The 12th question reads, how frequent is osmotic demyelination syndrome?
It's actually very rare because of the fact that we've kind of caught on to it and nobody is cavalier enough to kind of just let patients correct on their own. So anybody who comes in with hyponatremia, everybody's radars go up. So we keep a very close eye, at least over here, on these patients that need to be corrected. So we try our level best that it doesn't happen. So the frequency has primarily gone down significantly.
Okay, thank you. The next question reads, what will be the consequence if we managed a patient with SIADH with 0.9% of normal saline?
Okay, that is an excellent question. In the literature, you'll find, and for those physicians who've been practicing for a while, they will tell you that a poor man's way of diagnosing SIADH is to give the patient normal saline, and if the sodium worsens, then your patient has SIADH unless proven otherwise. And the reason why that is the case is, remember, when you make hypertonic saline, like I told you, right, 9 grams of salt in a liter of water. This same liter of water can hold 30 grams of salt as well. Agreed? And because of that, it means there's a lot of free water in that liter of water. Now, what happens when you give the patient normal saline? Does the patient need the salt? The answer is no. Does the patient, or is the patient primed to hold on to the extra free water that is there, that is not linked to any of the solute? Yes. So all that extra water kind of flows back in, worsening the hyponatremia of an SIADH patient. So theoretically, it might look, hey, I'm giving 9 grams of salt to this guy. The body is smart enough to say, hey, you don't need that 9 grams. So it's going to urinate it out. What's going to stick around is the liter of water that you gave that 9 grams of salt in. So you just diluted your patient out further. Hence, SIADH worsens with normal saline.
Yeah, thank you. The 14th question reads, how should we manage congestive heart failure and severe acute malnutrition patients? Can we give plumpinat for them? So plumpinat is the or it's commonly known as RUTF in our case.
Say that again. It's what is it called?
It's called RUTF. It stands for ready to use therapeutic feeding.
Oh, basically therapy. Okay, so refeeding. So the CH. So first and foremost, one would have to figure out why they have heart failure. If they are severely, and you said SAM stands for severely malnourished.
Yes, it stands for severe acute malnutrition. Severe acute malnutrition.
Severe acute malnutrition. So, are they running low on any of the vitamins? Right. I think if I'm not mistaken, and if I remember my medicine, thiamine deficiency can lead to beriberi or wet, so wet beriberi, if I'm not mistaken. So in that situation, that would be the first line of, I would check what is their B6, B12 levels, making sure that their vitamins are taken care of. The heart failure management would be separate from a standpoint of, yes, they need that heart decongested. Their severe acute malnutrition should be looked into and should be corrected appropriately as well, because they both go hand in hand, because the heart will need its own nutrition to be able to handle the load and get the work going, so that it can actually get rid of all the extra fluid that has piled up, either as a result of vitamin based malnutrition or acute malnutrition in itself.
Okay, thank you very much. So due to time constraints, we won't be able to address all questions. So the last question is, how do thiazides treat hyponatremia?
So thiazides don't treat hyponatremia. Thiazides can cause hyponatremia. Remember, when we, look at it this way. Any medication that you use for hyponatremia can cause hypernatremia, and any medication that is used for hypernatremia can cause hyponatremia. So we use thiazides for diabetes insipidus. And you will probably see this more often than not, that in the elderly population, thiazides can actually cause hyponatremia. So thiazides are usually not used to treat hyponatremia, they're used to treat hypernatremia.
Okay,
If you're
thank you
asking
very
how they, yeah, if you're asking how they treat hypernatremia, like I said in the presentation, they actually help the aquaporin 2 channels to be embedded, bypassing the V2 receptor. So whether there's ADH or not, you're using a separate receptor to put the aquaporin channel where it's supposed to be. And that's how hypernatremia can be controlled and improved with thiazides.
Okay, thank you very much, Dr. Hasan. So you've managed to address all of the questions in a comprehensive and patiently manner. So having said that, we'll directly proceed to the Q&A, to the post-CME quiz. We'll post the link shortly here, as well as on our Telegram, on our dedicated Telegram group. So attendees, you have approximately 15 minutes to attempt the quiz. And after 15 minutes, we'll recuperate with Dr. Hasan and we'll attempt them together.
Lovely. Thank you.
Thank you. So I'm sharing the quiz link here. Quiz link has been shared here. Okay, can you see my screen?
Yes, I can.
Okay, so the first question reads, a 40-year-old patient with hep C presents with nausea, right upper quadrant pain, blood pressure was 120/70, and pulse rate was 104. There was no orthostasis. Lab showed a sodium of 118, chloride of 89, blood urea nitrogen was 4, potassium was 3.5, and bicarb was 25. Serum osmolality was 290, total bilirubin was 14, alkaline phosphatase was 1524, and urine osmolality was 600. Total cholesterol was 2,621 milligram per deciliter with an LDL of 1,786 milligram per deciliter. Serum triglyceride, thyroid function, and cortisol were all normal, and liver biopsy showed inflammation with bile ductal proliferation and hepatocellular cholestasis. So the question is, which one of the following is true? A reads, the discrepancy of the measured and calculated osmolality shows that toxic alcohol ingestion is possible for these patients' complaints. B reads, absence of lipemic serum and normal serum proteins and triglycerides excludes the possibility of pseudohyponatremia. And C reads, if serum sodium were measured by laboratory autoanalyzer utilizing an ion-specific electrode, pseudohyponatremia, I'm sorry, I couldn't see the full. Pseudohyponatremia could be excluded. And D is, no additional testing is needed to interpret the serum sodium.
So C is the correct answer. Let's look at it from a different standpoint. Your patient is showing hyponatremia. No additional testing is needed to interpret the serum sodium is not going to be the right option because you will want to do more testing anyway. So D is out. If this was an ingestion or a toxic ingestion, you would want to look at the ingestion, the clinical picture of the patient would be different. So option A is not a possibility as well. Option B, just because certain portions of the lipid panel were normal doesn't mean that the rest of them were not. And as you can see, the LDL as well as the cholesterol levels were high. So there is a possibility that this patient is suffering from severe cholesterol issues that may have potentially led to the sodium or the serum sodium being low. Now, look at the serum osmolality of the patient as well. 290. At the algorithm that we discussed, and that will be available to you guys as well, this makes the patient fall in the category of pseudohyponatremia. And if the patient is falling in the category of pseudohyponatremia, and with the cholesterol being the way it is, it means that basically your patient is suffering from, or there is an autoanalyzer issue as far as the lab discrepancy is concerned. So if they were using a ion selective method, you would be getting the right answer, and I'm happy that most of you got this correct.
Thank you. The second question reads, A 30-year-old patient with recent brain tumor goes on an alcoholic binge. So she presented with history of vomiting and was mildly confused. Blood pressure was 120 by 80. Weight was 100 kg and heart rate was 100 beats per minute. There was no JVD with clear breast SAMs and no focal neurologic signs. And labs showed a sodium of 122, potassium of 3.2, and a chloride of 88. Bicarb was 29, and the BUN was 4, with a creatinine of 0.6 and a serum glucose of 90, with a serum osmolality of 270. So what is the best initial therapy? A reads 100 ml of 3% saline over 15 minutes. B is fluid restriction. C is isotonic saline, 1 liter over 1 hour. And D is Vaptan 15 milligram.
So this patient is hypoosmolar hyponatremia. You can tell that by the serum osmolality of 270. This patient has acutely had a drop in their serum sodium because, again, they've already had a brain issue, and on top of that, they went on an alcoholic binge. Because of the fact that they are already showing you that they are moderate hyponatremic based on the clinical picture. Remember, we did those 3: mild, moderate, and severe hyponatremia. Severe hyponatremia was complete coma, moderate and seizures. Moderate hyponatremia was headaches, confusion. This patient is going from moderate and may end up in severe situation. Hence, the option of trying to correct them appropriately with hypertonic saline would be the appropriate way to go. Fluid restriction will work, but it will take time, and it may or may not work depending on how much alcohol they've already consumed. Isotonic saline over 1 liter over an hour may or may not correct them to the right value. Vaptan, if they're already throwing up, it would be difficult for them to keep the pill down. So D is not the right option as well. Hence the option of 3% saline, which again provides you with coverage as well, you know?
Okay, thank you very much. The third question reads, a 50-year-old patient with a history of schizophrenia, hypothyroidism, and congestive heart failure is admitted to the psychiatry ward with worsening psychosis. You are asked to evaluate this patient for hyponatremia. In physical examination, patient appears agitated but is not acutely ill. Patient is afebrile and the sitting blood pressure is 120 by 80 with a pulse rate of 85. There is no orthostatic change in pressure or pulse, and mucous membranes are moist. Skin turgor is normal with no JVD and edema. Serum sodium is 127 and serum osmolality is 265. The rest of the electrolytes are within normal limits, and urine osmolality on admission was 60 milliosmol per liter, and urine sodium was 48 mol equivalent per liter. The most likely cause of the patient's mild hyponatremia is A reads SIADH secondary to antipsychotic medications. B reads psychogenic polydipsia. C is decreased free water excretion due to volume depletion. And D is decreased free water excretion due to hypothyroidism. And E is decreased free water excretion due to congestive heart failure.
Okay, so this is a good question. And again, it basically follows that same pattern that we were following from a standpoint of diagnosing or working our way through the question. So if you look at the patient's serum osmolality, it's low, it's less than 290. So they're hypoosmolar hyponatremia. Next is to look at the urine osmolality. The urine osmolality is less than 100, which puts them in the realm of the 4 diagnoses that we had, which include psychogenic polydipsia, T-toast, beer potomania, and acute water intoxication. If the urine osmolality was 600, I would have said that A is the appropriate answer. But because the urine osmolality is less than 100, it cannot be SIADH. So I'm happy that you guys are thinking the right way. Just don't jump because the patient was an antipsychotic medication and antipsychotics, antidepressants, especially SSRIs, anti-seizure medications can cause SIADH. Just because you see the question, don't jump on it. Just flow through that algorithm and you'll be able to get to the right answer. I think you all were thinking the right thing. I think the only confusion was that some of you did not look at the urine osmolality before answering. And that's why psychogenic polydipsia is the correct answer.
Thank you. The first and last question reads, a 50-year-old male patient with a past medical history of hypertension and bipolar disorder is admitted to the surgical intensive care unit after undergoing an emergency splenectomy for injuries sustained in a motor vehicle accident. Patient is on the ventilator and had a nasogastric tube. Patient outpatient medication included lithium and metoprolol. Serum electrolytes upon admission were within normal limits. And over the course of the next 2 days, her serum sodium increases to 152 mole equivalent per liter. Urine output is between 3 to 4 liters daily, and her urine osmolality is 75 milliosmol per liter. Urine osmolality does not change after the administration of 1 dose of vasopressin. So the most likely cause of her hypernatremia is A, read central diabetes insipidus, B is nephrogenic diabetes insipidus, C is increased respiratory water loss, D is blood loss, and E is gastrointestinal water loss.
Okay. So again, this is more or less a similar question that we did as an example. The patient's urine output is high. The patient's serum sodium is 150 and their urine osmolality is low, which means they have some form of diabetes insipidus. Agreed? Which means we are left with A or B as the option. Now, if this was central diabetes insipidus, repleting them with vasopressin or ADH or desmopressin would have corrected the issue in itself. The fact that they did not correct and are still continuing to put out high volume urine, as it says in the question, urine osmolality did not change after the administration of 1 dose of vasopressin. So that way, option B is the correct answer.
Thank you very much. So we've attempted all of the questions together. So on behalf of Yetenaweg and everyone that has attended so far, I'd like to thank Dr. Hasen for your exceptional presentation. Your expertise and clear, engaging delivery made the complex concepts accessible, and you provided our audiences with invaluable insights. As I have said earlier, we've received positive feedback, which is a testament to the impact of your contribution. So once again, thank you. I'd like to thank my co-hosts as well, Dr. Simone, Dr. Zaganish, and Dr. Masfin. And I would like to thank everyone that has attended with us so far. So this is the second series in our lecture series on common electrolyte disorders. The third is going to be held on September 7 with Dr. Hasen. So Dr. Hasen, we look forward to seeing you there as well. Thank you.
No, looking forward to it. And everybody who was able to attend, please thank the organizers. This is not easy to arrange and run. So a big thank you to everybody who was able to set this up for us. And looking forward to seeing all of you, if not more, on September 7th. I think we'll be doing acid base at that time.
Yes, correct.
Thank you, everyone. Pleasure meeting everybody. Thank you so much. You have a great day.
Thank you.